All right, ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Excited to be sitting today with a good friend, Sandeep Palakodeti. Sandeep is the founder and CEO at Velocity Health. Sandeep, good to see you today.
Good to see you, Mendel. Thanks for having me.
Absolute pleasure. So you've done 1.5 million things over the last bunch of years. Let's jump into what you're doing right now. So you're a doctor, and then you've done a bunch of things on the tech side, founding, co-founding, all over. What are you doing now? What's exciting?
So primary focus for me right now, Mendel, is what we call Velocity Health. This is a concierge precision medicine clinic. We are a 50-state national clinic in the cloud. We wrap around patients in a pretty intensive way. If you've been following some of the trends with Dr. Peter Attia or Huberman or all the wellness folks out there, there's a lot of information. There's a lot of data now. Function Health just bought Ezra. You can get a full body MRI for $500. Like, these kind of diagnostics are going to continue being commodities. But what we found are that patients are craving physicians and especially interdisciplinary teams that can help make sense of all of this information together, pull it all into one place, give them a good plan going forward. So Velocity Health, as I mentioned, is a concierge precision medicine clinic. What that means is patients come in, they are assigned a navigator, a member concierge who helps really, walk through the very complex healthcare system, figure out which things get paid for insurance, which come out of pocket. A health coach who's really their accountability partner and helps set goals, meaningful, smart goals that are achievable, attainable, really works through, small tests of change in people's lives. And then primarily a longevity and precision medicine trained physician. Most of us have training in either functional medicine or obesity medicine, lifestyle medicine, these kinds of things. And we go pretty deep with our patients, lots of different diagnostics, really understand risk many decades ahead of time when we can make a real impact. So that's what's exciting right now, Mendel. Happy to go into any detail about that.
Yeah. What's the is it cash pay? What's the payment model?
Yeah, it's cash pay. I think we found that so much of what we do is not amenable to the current system through, CPT billing or ICD-10s. And so we don't go through insurance. And we also believe that the growing trend of HSAs, ICRAs, most people are on a high deductible health plan. Folks are very price sensitive and conscious about how they're spending those healthcare dollars up front. And we think that should be spent in a comprehensive, preventive, primary way that really understands people in a degree that they've never felt before.
Yeah. So I love the work that you're doing. I think it's obviously really important and really helpful. I think that it's kind of a reflection of what's unfortunate about the system today. I was talking to someone earlier today, and we were saying how, unfortunately, if you don't have a friend who's a doctor, you're kind of screwed. If God forbid anything serious happens to you, if you don't have a friend that you can call and be like, hey, you're kind of screwed. And so you, it sounds like, are kind of offering that friend as a business model. And feel free to jump in if I'm totally off here, but that's what it sounds like. We're like, hey, we're going to hold your hand. We're going to explain things to you. We're also going to help you get ahead of the ball and be more preventive and proactive thinking about your healthcare. And, basically let's try to keep you healthy and your best you. And if God forbid anything's happening, we're going to help kind of walk you through that experience. Is that kind of what you're doing?
Yeah, absolutely. I mean, the dirty secret, Mendel, is that every one of us who are physicians, we pick up the phone when it's our own family member. We want the MRI when our kid is in the hospital and we don't know what's going on, right? 25% of our patients are actually physicians and executives in healthcare. And I think it's telling that clinicians seek a different level of care that we often prescribe to the general public. And it's you have to make these puts and takes and there's a broader sort of societal impact to think about. And, resource utilization is a big thing. But ultimately, if diagnostics, therapeutics were reduced back down to a cost that is extremely attainable for most people, you still need clinicians to help sort of explain what those things are and what those things mean. I think increasingly, AI will play some of those roles, just like patients used to come to us and have their printouts from Google or WebMD or whatever. It's just the next sophisticated level up.
But it's probably way different.
It is.
I mean, I'm actually, running joke was always, you Google your symptoms, you're dead. I mean, you have cancer, and end of story.
Right. Well, I appreciate in that way, though, that the recommendations now are more nuanced. I wouldn't trust it completely, and I think we're still 5 to 10 years off. But, having someone who you trust, who can spend 90 minutes with you and understands every aspect of your life and doesn't have some checklist that we're working through outside of your own best interest is what I think a lot of folks crave. And frankly, what I think they're paying for is access to clinicians and a clinical team that gives them that kind of understanding.
Yeah. It's funny, this little sidebar, but I have a friend who was in who's in a hospital, and I went to visit my friend, and I was alarmed. He had blown up, ballooned, insane. I almost didn't recognize him. And I was like, whoa, what is going on? And my immediate reaction was hey, go start. I spoke to one of the nurses, and I was like, he's going to sign an ROI. I want you to send me all the meds that he's on. And I'll run it through ChatGPT and figure out what the hell's going on. And they were telling me that my friend is going up and down 20 pounds throughout the week, just up and down. I know coming down is more scary because of kidney function and stuff like that. But it was just interesting. My immediate thought was all right, let me get all the info that's going on here, because you never really know what's going on in these hospitals. Let me run it through ChatGPT and just see what the deal is. But I mean, I know from my own experiences that it's definitely, it seems much more nuanced, like you said, and balanced and reasonable than Google. It's if anything, I find it to be very non-alarmist and being and you know what, that's also been my experience generally with doctors. Specialists maybe are different, but when you go to your primary care doctor, when you're taking your kid to the pediatrician, how many times you go there, then it's all right, keep an eye on it, let me know if it's still there in 2 weeks.
Yeah, there's a classic line. I don't remember if it's Hippocrates or whatever, but it's, healthcare is what we do to distract the patient while nature takes its course, right? God. And obviously that's not true in a lot of circumstances. There are all sorts of life-saving and life-altering interventions that we do. But, I think by and large, we don't have enough of a clinical workforce in this country to handle the needs of our population. So some aspect and some care, and I think that we're smart enough and nuanced enough to segment out care to things that are quote unquote low risk. And yes, there will be a small percentage failure rate there. But if most people could get the answers they need to 80% of the things they're coming to doctors and other clinicians for, and we have high reliability, the open evidence of the world, the folks that have really tailored the LLMs to healthcare, then it's not that far off, Mendel, I think, before a pretty big segment of healthcare is taking care of it that way.
Yeah. So one of the kind of probable, or I'll say possible downsides to the model that you're taking, I think the pushback to a lot of the names that you said earlier, all the cold plunge folks, whatever, the whole crew, is that sometimes it's just too much. You can go down these rabbit holes and you turn into Brian Johnson, or at least the man's trying to make a buck off it. You got to respect the hustle. Yeah. But some people, they go down and then they go too far. And I think that when the services are kind of tied to risk, right? Well, when they're tied to outcomes, then you, by nature and by the definition of the incentive structure, you're forced to keep that balance, because it's hey, when I'm spending my money, I'm going to make sure that I'm getting the best bang for my buck, and spending on prevention when necessary, but not overspending on prevention where I don't think it's going to actually improve any kind of clinical outcome down the line. And so how do you kind of think about that balance, if at all? Yeah. What are your thoughts?
Yeah. Look, we make $0 off of any supplements, any tests, any affiliate codes from the cold plunge or the infrared or whatever. I'd say we focus on the core four, which are diet, exercise, sleep, and mental health. And I haven't met a patient yet in this, many years of practice that couldn't optimize something along those core four. And so once you start working on that and people are totally dialed in with their body fat and their insulin resistance and their hypertension and their composition, like, sure, they want to start exploring things like supplements or peptides. We'll give them that guidance. But ultimately, we meet people where they are, and folks are coming to us for a certain reason. And we're not, again, the types that are shilling anything because we have no incentive to do so. I think there is a future where this gets paid by a third party, like an employer as well, because what we're really wanting to show and have shown are decreases in hardcore clinical and utilization metrics, like decreased ER visits, decreased hospitalizations, improved A1C, improved blood pressure, decreased, cardiac events. These are the kinds of things that people care about from a wellness and prevention standpoint. I think, it's unfortunate that everything else kind of gets lumped into that too, like the cold plunges and the supplements or whatever it is. While they all have their place, there's no one panacea for everyone, right? And so that's why we've taken this pretty interdisciplinary approach to dispel some of that. People come to us all the time and say, I saw Brian Johnson talk about this thing. What do you think? We'll talk about the evidence and decide where that fits on the priority list versus their ApoB being 200 and their, insulin resistance being extremely high. So there's nuanced conversations about all of these.
I mean, so you and I were talking right before we started recording, some notes from my podcast with Abe Sutton, and something that we talked about there that I've explored quite often. And it sounds like you're pretty much doing this. It obviously would have to be like, and I hope you just scale to, millions of patients, because it would have to scale to millions of patients. But the idea is that, like, one of the biggest issues with healthcare and value-based care is that the patient, and this only hit me like a year ago, I don't know why, but the patient can choose who insures them, which, as it should be, because we live in America, we're free people, right? But how then do you expect somebody to invest in an asset that the asset can decide who the next investor is basically the issue that you come up against. And like the analogy that makes sense in my brain is like, imagine if that was like in real estate. Imagine that the house was able to decide who owned it the next year. And then you come to the owner and you're like, okay, you bought this property. We want you to redo the gutters and the plumbing and, the roof. And you're like, well, I would do that if I knew that I had this property for the next 100 years, but the property gets to choose next year who owns it. So like, I'm not going to put that money in. Right. And in America, at the end of the day, it's like pre-Medicare, post-Medicare, even though there's obviously, a lot of whatever, there's commercial and there's mid-payer and there's Medicare Advantage. There's a lot of mess in there, but there's that line I think that people are looked at. And there's no consistent partner, what sounds like you can be, or maybe this is what you are. There's no consistent partner that's hand-holding the patient. And so like what we had explored a couple times, which sounds exactly like what you're doing, is like there should be an entity that is essentially hand-holding the patient, belongs to the patient. And it belongs to that patient no matter the payer. And the incentives that any payer are going to have are the things that you are working on, which is prevention, health, wellness, et cetera. Right. And those are, and like, that should be tremendously valuable to, like, all the payers technically should pay into a pool that should pay you, Sandeep.
Yeah, I mean, it's a super interesting concept. I mean, Sachin Jain used to talk about this all the time and still does, that the 1-year contract in Medicare and in any health plan, commercial included, it doesn't make any sense because everyone continues to pass the buck on why would I, as I'll just say them, right, United, cover a patient's preventative care, identify a cancer up front if I'm not going to see the downstream benefit of having identified that earlier on. In fact, I might be generating more cost for myself because now I have to go take care of it, right? If I can just put the blinders on, then I just hope that person chooses a different plan. I'd say it's probably not the individual's choice as much as we think, right? Their employers are often the ones that are making these decisions on their behalf. Sure, they could like opt out of their employer base, but in a lot of ways, there is no reason why a patient, a member, an employer would continue to pay us our premium PMPM every month unless we were posting real outcomes that mattered to them. And to your point, we would want to follow these folks throughout their, working years, commercial years, where they are given dollars to allocate in their own way and follow them into Medicare. I mean, I think what you and Abe were talking about, like having a health span sub MA plan, like a SNP for MA patients who are willing to lock in to one payer for 5 years or, one medical group for 5 years and let them really do all the things up front, I think would be an amazing demonstration project, right? Like 5 years isn't that long. We can do that experiment over the course of a couple of administrations. So, that would change the paradigm, but I think there's always going to be those market pressures to have 1 year contracts for as long as we let that happen. Random idea.
Have you ever thought about partnering with life insurance companies?
I think yes. So we have approached several, and if there are any life insurance listeners out there, we'd love to chat with you because there are interesting entities who are very aligned in our incentive as well. I want to keep my patient alive and healthy for as long as possible. You think about, especially high ticket beneficiaries where the face value is 10 or 20 million dollars, like there's no reason why the life insurance provider wouldn't spend 10 or 20 or $50,000 a year to essentially protect that asset for as long as possible, to keep them from, morbidity or mortality. So yes. And I think that they are an interesting entity that we would, love to partner with.
I think it makes so much sense. I have to think through it a little more, but the thought was, which obviously you thought through, but just to spell it out, the thought was they are the one insurance that is insuring somebody for their entire life. And they do not want that person to die early because then they have to pay. And that's the whole business model. And in fact, there is a direct incentive, just like with Geico, if you download the app and then they follow you to make sure you're not speeding, you can pay lower premiums. There should be a direct incentive where, hey, if you sign on to this service, you will have lower life insurance premiums because you're less of a liability.
A lot of these life insurance carriers will give people like a 30% discount on their premium just for wearing a wearable and checking in with, their gym once a month or whatever, right? Like easy stuff like that. Tacking on something like this should, I think, ostensibly decrease premiums by at least 50% and mitigate that risk, especially if they lock in for multiple years.
Let's ask our friends at Perplexity. I'm curious. What is the number one thing that people who collect life insurance not premiums, what's the actual payout called? Whatever, collect life insurance, die from?
I'm guessing it's the same things on a population level, like heart disease and cancer, COPD.
It's heart disease, cancer.
Interesting.
And then there's strokes, accidents, respiratory disease, other natural causes. And I mean, look, you're not going to be able to prevent a car accident, but if the number one thing is heart attacks and cancer, that's the same thing that's, killing all of us as Americans. Then this should be a pretty, makes a lot of sense. Done. Okay. we just got to find some life insurance companies, but definitely makes a lot of sense. Super interesting. So what does the actual experience look like? So I'm a patient. I sign up with you directly. What is what happens? What's kind of my onboarding or whatever?
So we understand healthcare is complicated. We want to give you as many resources as possible. You fill out a pretty intensive questionnaire and intake form with all your past medical history, things like that. We work with a lot of busy executives and, former and current athletes, busy parents. So we often will do that step over the phone with folks as well with their concierge and just kind of run through, who you are and what your risk factors are. Mm-hmm. We then introduce you to your health coach, and together you really set goals for, why did you sign up with us? What are your primary things you're thinking about? Tell us a little bit more about those core 4 things like sleep and stress and diet and exercise. And then we have what's called your physician pathways meeting. So this is just a meet and greet, a 30-minute conversation where we understand everything about each of our patients, and then we really rationalize the diagnostic set. That's the point of that conversation. There's a lot out there that we can get. Some people come to us and say, I am high risk for cardiac events. My father passed away in his 60s, like my parents. Three of my grandparents passed away in their 60s from heart attacks. Both my parents have diabetes and had a lot of, heart disease early in my family. So we might say, okay, for Deep, we're going to do a cardiac CT angiography and all of our biomarkers and really understand his cardiac risk and his metabolic risk. Mendel, maybe you come to us and say, well, my uncle and my mother were diagnosed with cancer early in their lives. I'm coming to that age. I've got kids. I really want to make sure that there's nothing there. So we say, okay, well, we have access to the liquid biopsy, the GRAIL test, and the Prenuvo full body MRIs. And, based on your age and risk factors, we'll schedule you for your colonoscopy and your Lido CT scan, and let's do the full sort of test. And so that pathways visit is really meant to understand which sort of diagnostic set are we going to start with. Ultimately, we get to a lot of that with most of our patients, but it can be overwhelming, right? Just the things that I just mentioned, you're shuttling here and there and getting all this information back. But the point is to ultimately create the most comprehensive view on your health and you as a person that's ever been created. And so that comes with hundreds of biomarkers, thousands of genetics, SNPs and all sorts of imaging, et cetera. And so we pull that all together, and then you meet with your physician, again, trained in longevity, optimization, lifestyle medicine, these things. And they really put it all together from a root cause analysis, help you understand what are the biggest drivers of your risk, what's going to kill you in the next 10, 20, 30 years. Our goal is we meet people where they are, but we like to project out, where do you want to be in 30 and 40 years? Most of our patients are somewhere between 40 and 60 years old and in the prime of their lives and career and juggling a lot and are looking towards that next generation. Maybe you're taking care of parents or others in their sphere and are seeing what they want to make sure doesn't happen to them as well. And so from there on, you meet monthly with your health coach and quarterly with your physician and have access to subspecialists and behavioral health on our team as well. And all of these diagnostics that we talk about are all sort of included as well. So pretty comprehensive. People have to be at the right sort of phase of life, I'd say, and ready to make the commitment. As you can tell, there is a lot here to do, but people will largely be selecting in or out of this experience based on that kind of description.
Yeah. So all that is like kind of health, wellness, prevention. What happens if I get sick as a patient? Are you also like my primary point of contact? I'm like, hey, I'm not sure about this thing. What do you think? Am I going to the ER?
Yep.
Do I I don't know, a couple of years ago, I tried a all meat diet for like 6 weeks.
Yeah.
Lost a bunch of weight and got a kidney stone. So I remember, and again, this is back to like, thank God I have a friend who my friend happens to be my PCP, but I was like, something's wrong. Something's very wrong. Yeah. Called them up.
Definitely. We definitely take care of that kind of stuff. So we have 2 different plans. For our premium plan, yes, we are the 24/7 concierge doc. For the most part, that's what we play for most people because they trust us more than anything. Is, how many times do you get 90 minutes with your doc and you're emailing them back and forth, you're finding some article. So we get questions from patients all the time about those kinds of things. We're here and available 24/7 to answer questions and to help triage everything. And we become primary for most people.
Yeah. Awesome. And then obviously this doesn't replace insurance. You're still, you want to have insurance for the actual, God forbid, procedures or surgeries or whatever ER visits that are necessary or anything like that.
My real vision for the future is the blueprint for a new American healthcare is I think giving people more control of their healthcare dollars will allow smarter and more personalized allocation of those resources for whatever people need. So, again, my dad, who's got multiple stents and diabetes and, other risk factors, he probably needs sort of traditional insurance, at least MA, where he can be seen by a lot of different physicians and be sort of in network, get whatever procedures and meds that he needs covered. Someone like me, I should have the freedom to basically opt out, have a comprehensive program like Velocity Health that wraps around me and my family, or a direct primary care option somewhere where I can, have really consistent access more than anything, pay cash for any procedures or tests or imaging that come up. Increasingly with price transparency rules and tools, there's a lot more pressure there and opportunity market, forces as well that are pushing down the cost of these things, and then have catastrophic insurance, like you mentioned. If God forbid something really bad happens, then indemnity over $10,000, or even these health shares type organizations like Crowd Health or Christian Ministries. So, I think that that's a perfectly acceptable way. I mean, if you follow this stuff, right? Premiums for a family now, or healthcare as insurance costs are probably $25,000, $30,000 at least a year. How tenable is that? We can't. So, without going down or on the soapbox too long on VBC, I believe value-based care is a step up from fee-for-service medicine. But ultimately, if the promise was we are bending the cost curve, I think there are plenty of examples that show that, but it's not happening at scale to the point where we are decreasing premiums for everyone across the board, right? We're not having health insurance companies return premiums because they posted such a low cost ratio. And so it's largely, we're in the phase where we're largely reallocating dollars from certain entities like health plans to, risk-bearing providers, I think. And I still think that's better than the status quo. But we're a long way off from what I think is really investing in primary prevention, which should pay off in the long run. So I hope to see some of these principles, these longer contract terms, this real upstream, approach imbued into more BBC.
You have a massive advantage, though, because at the end of the day, you're the demographic that's going to buy Velocity is going to be, middle upper income folks, just practically speaking. That means that you're actually paying for it. And there's huge power in paying for your own healthcare. And especially if you're in that like middle to upper class, where you're not like super wealthy, but you're like there. So the dollars are meaningful to you. But at the end of the day, the other issue that I've talked about for years is we try so hard to care for people, and you have all these countries that and there's Medicare and Medicaid, and you have all these countries that have fully free healthcare, but then you're completely disconnecting the incentive structure from the actual consumer and the actual user, and you're putting the incentive structure strictly on the doctor. Even in value-based care, if I'm taking value-based care contract for MA or for Medicare or whatever, it's really difficult because the sense is almost like it's my doctor's problem that I'm healthy or not, because I don't pay for it. And the only cost is me and my life. But unfortunately, we don't tend to look at things like that, because the decisions that you make today, typically only affect you in a bunch of years, especially the behaviors that you learn. And there's something really powerful about paying for your healthcare, because you do start making more conscious decisions. I mean, even, you mentioned health shares earlier. I'm part of a health share, and my wife will say all the time, half jokingly, but not really, like, oh, we can't do that. Don't do that, Mendel, because, we have a high deductible, we have a high,
Right,
so it's
right.
like, so I think there's massive power in the patient being equitably involved in the kind of incentive structure part of the decision-making process of like how to operate their lives,
Yeah, I totally agree. And again, people are self-selecting into this. So it's, we're very lucky to work with a group of patients who are highly motivated, who are by and large double paying for healthcare in some ways, right? They get quote unquote access through their insurance through a PCP, but they're making the decision that that's not adequate for them. And there's all sorts of behavioral economics that show when people pay for something and even potentially have that loss of those dollars at risk. I mean, they are much more likely to stick with certain behaviors. And so if you're investing what you're investing to be a part of our practice, then there's a little bit of a subconscious pressure on yourself to continue to see the value in that, right? And it's kind of like paying for a personal trainer, a gym membership, or whatever. And we have people that fall off. Don't get me wrong. I mean, probably 4 or 5 months in, just like most, sort of journeys in life, people lose enthusiasm. They, life happens again. They get back into their old habits. And that's where we're really, pulling patients back in. And, one thing we haven't discussed is another thing you were chatting about with Dr. Pearl, which is using wearables, using devices to really connect to patients in real time. I think the sort of the narrative of our lives are so rich between every interaction that we have with our clinical team that it's almost crazy that we make decisions just based on our 1 10-minute interaction with patients in the office, right? And their whole lives and the fabric of everything they're doing is quantifiable in some ways. I think there's, a discussion to be had about the quality of that data and how we use that data. But in our practice, it's been really interesting to connect with patients in between those quarterly visits when we see, for example, their heart rate variability goes down and their resting heart rate goes up and their step counts go down. We can check in on them. We get our pings. We are unleashing sort of our technology to understand what's going on. Are you actually feeling sick? Are you out of town? Are you not wearing your wearable? Like, what is it? So that kind of proactive and sort of real-time approach, I think, is another fascinating aspect of it that's going to meaningfully change outcomes and how we approach medicine.
Yeah. Cool. So 2-part question for you. You've had a lot of previous experience in venture. I think you exited one of your previous companies.
Yep.
Would love to know how that was. And then did all that kind of lead to this? Are you like, obviously subconsciously, you're definitely packaging all that knowledge into this new experience, but was there anything like specific that was like, okay, I kind of learned these different pieces and now I think I've got all the ingredients to make this cake, called Velocity?
Yeah, I appreciate that question. My dad's a family physician and was in the same practice for 45 years or something and got to see healthcare through his eyes in a lot of ways and see the very broken system. And so everything I've tried to put myself in was around pushing the limit on how we deliver care in this country, because I know we can do so much better. I look at all of my amazing colleagues and friends and people I've worked with, and I mean, brilliant people who care so much about their communities and their patients. And our system is so broken in so many different ways. And so, I was at Kaiser. I did a fellowship at Harvard in healthcare innovation and entrepreneurship. I was at the Mayo Clinic, and through those experiences had started my first startup, built that, and ended up selling that a couple of years later. And I think through that lens, realized that there's a lot of different attack vectors that we're going to need to activate in order to make real change in healthcare. Government and policy is one of those, and payment schemas from single payer to fully capitalistic approach are there's a big spectrum there, but there's so many other ways to impact health: NGOs, nonprofits. To me, I've found that entrepreneurship is the most potent vehicle for societal change that I've found yet. To be able to identify problems, wrap it into a solution that someone's willing to pay for that actually delivers value back to the world in short order, I think has been a theme that I've sort of pursued. I've tried that at big health systems. I was the chief population health officer at a big health system in Cleveland, and the scale at these kind of places is amazing. I got to help oversee our ACO with 600,000 people and our employee health plan with 35,000 people. And, in our VBC world, those kind of numbers are like deca unicorn type companies, right? But that's just like anywhere America has that many patients just assigned to their hospital systems and health systems. So I think change needs to come from those kinds of places, those stalwarts, those institutions that are not going anywhere anyways. But I think it's going to be shown by practices like ours. And I think the VBC was really the tip of the sphere. But again, to me, it was a lot of, restacking the chairs on the deck of a sinking ship. Like, we're just reallocating dollars, but overall the healthcare costs continue to rise every single year. So what do we need to do to actually stop that? Well, we need to exit the insurance-based system that in some perverse ways has incentive to increase healthcare costs as well. The fee-for-service engine, and really start asking ourselves what's the kind of care we would want for ourselves and our family. So, I've managed the big P&Ls, the big teams. I've been in cool startups and in large institutions. And I think all of that has led me to this moment that we have so much information and knowledge on the medical and clinical side on how we can and should stay alive for many decades to come. And I now personally think, me and our team have the experience to do something like set up a 50-state MSO PC model and understand all the nuances and regulatory aspects to that and all the licensure aspects so that we can bring access to every sort of corner of the country. And so I'm excited. I think more and more clinicians are coming to me every day asking, like, well, how'd you do this? Because I want to do this. I can't stick in the system any longer. I can't be pursuing RVUs, at the expense of, my kids' baseball games and charting at 9. It's insanity. So, we all chip away at healthcare in our own ways to show where the opportunity really is. And I'd say this is my my attempt at doing that myself.
That's awesome. This is very cool. A lot of people talk about this. A lot of people pontificate about this. A lot of people do kind of smaller pieces, like concierge medicine is kind of like a version of this. But you seem to be really focused. And again, I really recommend everyone to go check out even just your LinkedIn and look at the number of experiences, because it matters, I think. And you're not just obviously actually a doctor yourself, but you seem to be really focused on how you can make this work. I think you've dialed in your demographic, it sounds like who this is for. And I don't think you're going to end there personally. I think this is going to get really big, and it's going to expand beyond the current demographic. But I think this is where I think you're really spot on with where you have to start if you actually want to see results. And then you can learn from those results to expand that pool out to kind of lower income and trying to start to figure out those other groups. And that's fine, but there's a lot more complexity there. But stripping away like this, a lot of times I get into these conversations and I feel very overwhelmed by the complexity that it takes to make this thing work. And I don't feel that way in this conversation. Like it kind of makes sense. You know what I mean? You sign up for this thing.
Yeah, I think there's a huge look. We want to democratize this as much as we can. And I think that there's all sorts of ways we can do that through education and, bringing our knowledge and expertise to as many people as possible. But we've had the exact conversation of how do we do longevity medicine for the homeless or for those on Medicaid. And it seems like stupid in some ways, like the dichotomy there and the juxtaposition of those kind of themes of what people care about in their lives are different, right? But ultimately, like, this is primary care to the extent that we'd all wished it was. Like, that's what I really thought primary care was going to be. And if we can show this, like, I remember the PMPMs and costs for Medicaid populations, complex ones that I took care of, like, you invest a third of that into a service like ours that's highly reactive and able to see these folks. Like, yeah, I think that we can make a difference on government programs and resource poor settings as well. So it's not just for the worried well. It's not just for the wealthy amongst us. It really is a new paradigm of understanding proactively as much as we can. I really believe, Mendel, if we live for the next 10 or 20 years, it's very likely that we'll live for the next 40 and 50 and 60 years. Like, that's not hyperbole at all. Just think about the pace of change that we've seen in 2 years since AI came on board. Can you imagine 20 years of that being unleashed in healthcare? The name velocity really came from the idea of longevity escape velocity, which is we will all reach a point where life expectancy is getting pushed out by 1 or 2 years every 1 or 2 years. And so we just kind of never catch up. So what that means for society, for families,
grab
for
a drink at
entitlement,
180, shall we?
Yeah, I mean, who knows if we don't kill ourselves all before that. But, I think that's the kind of future that we're sort of building towards, is that it's very likely that we are working on 10 and 20 and 40 year time horizons, not just 1 and 2 and 5 years.
That's awesome. Well, this has been a pleasure. I'm pulling up your website. Everyone can go check it out at
velocityhealthclinic.com.
There it is, velocityhealthclinic.com. If you're a patient, you can sign up here. I'm guessing limited memberships book now. That's for patients. Go check out their plans. Yeah.
Absolutely. Well, I really appreciate you having me on, Mendel, and for all of the great conversations you're having across the healthcare industry, the insights you're bringing. I think there's a lot of buzz around this, and I think that there's actually a really interesting tie-in to a lot of the VBC world that we also live in.
Thank you so much.